Bismillahirrahmanirrahim. Today we will be discussing the remaining vascular tumors. We have discussed in previous lectures about the benign vascular tumors. Today we will be discussing about the intermediate grade neoplasms and the malignant neoplasms. Among the intermediate grade neoplasms, there are Caposi sarcoma and Hemengio Endothelioma. And among the malignant neoplasms, there is Angiosarcoma and Hemengio Pericytoma. Now, first of all, the Caposi sarcoma, which is an intermediate grade neoplasm, and it is caused by the human herpes virus 8, that is also referred to as the Caposi sarcoma associated herpes virus. It has 4 classical subtypes. The first one is the classical Caposi sarcoma or the European Caposi sarcoma. The second one is the endemic or the African Caposi sarcoma. The third variety is the epidemic or the AIDS associated Caposi sarcoma. And the number 4 is transplant associated Caposi sarcoma. So the first variety, the classic or the European Caposi sarcoma, it is a disorder of older men of Mediterranean and the Middle Eastern descent. And this disease characteristically has an indolent course and it is rarely fulminant. So it is the benign type of Caposi sarcoma. And it starts as red-blue inflamed looking lesions on the distal aspect of the lower extremities. And over the course of years, the lesion becomes widely distributed and nodular. And there is occasional lymph node and visceral involvement in this variety. So it is an indolent variety of Caposi sarcoma. The second type, that is referred to as the endemic or the African Caposi sarcoma, it occurs in HIV seronegative individuals of African descent, and it is prevalent among the black African children and young men. And it has the same geographical distribution as the Burkitt lymphoma, and it is an aggressive variety because it involves the lymph node and the viscera, that is the liver, lungs, spleen, and it is fatal and death occurs within 2 to 5 years. The third type of Caposi sarcoma is all referred to as the transplant associated Caposi sarcoma, and it occurs in individuals who are the recipients of organs, and they are treated with large doses of immunosuppressants. So the lesions are either localized or widely metastatic, and it has an aggressive course just like the case of African Caposi sarcoma with lymph node, visceral and mucosal involvement. The fourth variety of Caposi sarcoma is referred to as the epidemic or the AIDS associated Caposi sarcoma. It occurs in HIV positive individuals that have AIDS. So it occurs in individuals who are immunosuppressive. So it has early dissemination to lymph nodes and viscera. It runs an aggressive course, and 1/3 of these individuals develop a secondary malignancy, that is usually a lymphoma, and death occurs within 2 to 5 years. And mostly this is the disease of the homosexual men. Now coming to the pathogenesis of Kaposi sarcoma, the Kaposi sarcoma is caused by the human herpes virus 8, that is also referred to as the Kaposi sarcoma associated herpes virus. This is the variety of gamma herpes virus subfamily, and it is transmitted sexually or by the non-sexual routes including the oral secretions or the cutaneous route, that is through different cuts and scratches. So 95% of these lesions are known to be human herpes virus 8 infected. So there is the possible roles of T cell mediated immunity. There is suppression of T cell mediated immunity or the primitive mesenchymal or endothelial cell derivation of tumor cells. And for AIDS-associated Kaposi sarcoma, there are locally produced growth factors that cause unchecked growth of the tumor cells. 95% of the Kaposi sarcoma lesions are shown to be Kaposi sarcoma associated herpes virus infection. Now coming to the characteristic morphology of Kaposi sarcoma, the Kaposi sarcoma disease has characteristic three stages: the patch stage, the plaque stage, and the nodular stage. So in the patch stage, on gross examination, the person develops pink, red to purple, solitary or multiple macules that are usually confined to the distal lower extremities. On microscopic examination, it has the same resemblance as the granulation tissue. That is, there are abundance of the blood vessels which could be dilated or irregular, and they are lined by the normal looking endothelial cells, and in between the blood vessel there is mixed inflammatory infiltrate comprising of the lymphocyte, plasma cells and macrophages. And you can very well understood that this is the same histological appearance of the granulation tissue, the blood vessels and the mixed inflammatory infiltrate. The second stage of Kaposi sarcoma, that is the plaque stage. In this stage, the characteristic patches become fused and they spread proximally and convert into the large plaques that are the dermal dilated jagged vascular channels, and they are lined by the plump spindle cells. So the vascular channels that are in the patch stage, now they become dilated and irregular, and in spite of normal looking endothelial cells, they are lined by the plump spindle cells, and in between these vascular channels there are extravasated RBCs, the hemosiderin laden macrophages, the lymphocytes and the plasma cells. The third stage of Kaposi sarcoma, that is the nodular stage. In this case, these vascular channels become inconspicuous, and there is characteristic proliferation of spindle cells that are lining these vascular channels. So in this stage, the lesion become characteristically more cellular and anaplastic, that these spindle cells develop certain anaplastic features. There is nuclear atypia, there is increase in the mitotic activity. So in this stage, the vessels become inconspicuous. So these vessels appears as small vessels and the slit-like spaces that contain the rows of cells in a boxcar pattern. So this is the characteristic gross and the histomorphological images of Kaposi sarcoma. The first figure on the left side is the patch stage, in which there are red to purple macules which could be solitary or multiple on the distal lower extremities. And in the histological appearance, there is abundance of the blood vessels lined by the normal looking endothelial cells, and in between these blood vessels there is mixed inflammatory infiltrate. And in the second figure, you can see that these patches fuse together to form characteristic plaques, and histologically the blood vessels become more conspicuous and they are irregular, jagged, and in spite of normal looking endothelial cell, they are lined by the plumper spindle cells, and in between these vascular spaces there are RBCs, hemosiderin laden macrophages and mixed inflammatory cells. And in the third figure, there is appearance of nodules on distal lower extremities, and histologically the vessels become inconspicuous and there is more cellular area comprising of more spindle cells that may form solid masses, and in between these spindle cells the blood vessels appear as slit-like spaces. So this is the diagram of your robin. In the figure A, there is characteristic plaque stage that are red to purple violaceous plaques on the foot, and in the figure B, there is characteristic proliferation of spindeloid cells with irregular slit-like blood vessels. So now coming to the next intermediate grade neoplasms, that is the Hemengio Endothelioma. It is an intermediate grade tumor between well differentiated hemangioma and the frankly anaplastic Hemangiosarcoma. So it follows the pattern of distribution of hemangiomas and is most frequently present in the skin but affect the spleen and liver also. And epithelioid hemengio endothelioma is a unique type of hemengio endothelioma that occurs in medium-sized veins in the soft tissues, and they are often misdiagnosed as metastatic tumors. And in epithelioid hemangioendothelioma, the vascular spaces are inconspicuous, and there are single rows of plumb cuboidal neoplastic cells. So these lesions tend to recur in 40% of the cases, 30% of the cases metastasize, and 15% of the cases die. So epithelioid hemangioendothelioma is more characteristically seen in the liver. Now the malignant neoplasm, the most common malignant neoplasm is the hemangiosarcoma or the angiosarcoma. It occurs in both sexes and occur in older individuals, and it is most commonly present within the skin, soft tissue, liver and spleen. And it has a poor outcome with a survival of only 5 years, and it can occur within the setting of lymphedema that typically occurs after the axillary dissection in patients who have undergone mastectomy for breast carcinoma, followed by the neoadjuvant chemotherapy and the radiation therapy. And it can also occur in the liver, and in the liver has most common association with certain chemical carcinogens including arsenic, and the pesticides the contain arsenic, then thorotres, that is a radioactive contrast, and the polyvinyl chloride that is used in plastics. So the morphology of angiosarcoma, it is a malignant vascular neoplasm that has a more solid appearance. It is characterized by irregular jagged vascular spaces that are lined by the plump and highly anaplastic endothelial cells having high NC ratio, nuclear pleomorphism, brisk mitotic activity, and atypical mitotic figures. And on gross examination, the lesions are sharply demarcated, and there are multiple red nodules that become fleshy masses of pale gray soft tissue. So these tumors are characteristically positive for vascular endothelial cell markers. So immunohistochemically, these are positive for CD31, CD34, and there is a recent marker that has gained importance in the diagnosis of vascular neoplasm is the ERG. It is an endothelial transcription factor related immunohistochemical marker of the ETS family, and it is a nuclear transcription factor that has a characteristic nuclear positivity, so it is much more sensitive and specific. So clinically, angiosarcomas are locally invasive and they can metastasize rarely, and these are aggressive tumor with a current 5-year survival rates approaching 30%. So this is the characteristic gross appearance of the angiosarcomas involving the heart ventricles. And in the second figure B, there is a characteristic histomorphological image or the microscopic image of the angiosarcoma showing typically cytologically anaplastic cells. And third is the figure of immunohistochemical stain CD31 that has a characteristic membranous positivity that is highlighting the endothelial cell positivity in angiosarcoma. The second type of malignant neoplasm that is very rare is the Hemengio Pericytoma. It can arise from pericytes, which are myofibroblast-like cells associated with capillaries and venules. So it is rare tumor, and the solitary fibrous tumor of the pleura is also thought to be the derivative of Hemengio Pericytoma. Now briefly, at the end of the chapter, we will be discussing the pathology of the vascular intervention. The common vascular intervention that are used these days are the endovascular stenting and the coronary artery bypass surgery or the bypass. So most commonly these endovascular stent procedure in use in patients having acute MI in which there is coronary artery stenosis. So whenever the patient presents in emergency, first what we do is that we add or we pass a balloon catheter that will reopen the vessel. But this balloon angioplasty alone has no added benefits because the arteries subsequently undergo reclosure by longitudinal dissection, vessel wall spasm, or by thrombosis. So whenever balloon angioplasty is done, the surgeons mostly place a coronary artery stent. This is the metallic mesh, the expandable tubes of metallic mesh, that after we pass a balloon catheter, we place a metallic mesh over there that will keep the vessel wall lumen open. However, coronary stent placement also has certain complications and disadvantages because post-op thrombosis is common and instant restenosis occur by intimal thickening, smooth muscle cell proliferation, and extracellular matrix synthesis. So occlusion of coronary artery stent occurs within 6 to 12 months. So recently there is evolution in the coronary artery stent placement, that there are drug eluting stents, that these stents have certain drugs that are anti-proliferative and they limit the smooth muscle cell activation. So as a result of which the disadvantage or the incidence of restenosis at 1 year is decreased by 50%. So these are the recent advancements. The second common vascular intervention is the vascular replacement. In this case, the damaged coronary artery is replaced by either an autologous or the synthetic vascular graft. The synthetic is the vascular graft that is not taken from the person, and the autologous vascular graft is the vascular graft that is taken from the same person in which we are doing the vascular replacement. So it is used to replace the damaged vessels or to bypass the diseased vessel. So the small diameter vascular grafts fail as a result of thrombosis and intimal hyperplasia. So for coronary arteries, the bypass surgeries, the grafts are usually taken from the saphenous vein or the internal mammary arteries. However, the grafts that are taken from the saphenous vein have lower patency. They have a 50% patency at 10 years as compared to those taken from the internal mammary arteries. They have 90% patency at 10 years. This is the end of our chapter of blood vessels. In the next week, we will be starting the second important chapter of the cardiovascular system, that is the heart. So thank you so much for patient listening.